Hello and welcome to Why Medics Matter, a podcast for doctors, by doctors training. We are your hosts. I'm Dr Amie Burbridge.
And I'm Dr Simon Fruser.
And today we are joined by Dr Jason Hancock. He is a consultant psychiatrist and director of medical education with an interest in uncertainty. Jason, would you like to tell us a little bit more?
Absolutely, yes. Thank you very much for having me here today. It's great to be speaking with you. So as you've said already, I'm a psychiatrist. I'm a director of medical education. I've always had a particular interest in education and how we can support and train our doctors to develop the skills that they require to be excellent doctors. And I think uncertainty, for I guess reasons we'll talk about shortly, is just such an important skill for resident doctors and for all doctors that it's something I've been particularly interested in throughout my training. And I've been lucky enough to combine a job and a role that allows me to research that and also to research how we can best support our resident doctors to develop more positive responses to uncertainty, and also how we can help supervisors to help their resident doctors develop those more positive responses to uncertainty.
I'm going to start with a question. As an acute physician, I deal with uncertainty all day, every day. But what I'm noticing is that why do we even bother with uncertainty? We have so many investigations. We have AI. We have genomic sequencing. Aren't the answers all there for us? Is uncertainty a thing of the past?
Well, I think you probably won't be surprised to hear me say, no, I don't think it is a thing of the past. As I think it's integral to our roles as humans and as doctors. I can start with a definition, because I think often when talking about uncertainty, we all kind of know what we mean, but we might not necessarily mean the same thing. So when I mean uncertainty, I'm using Hillen et al.'s definition. I think uncertainty is conscious awareness of a ignorance about a particular aspect of the world. So what I mean is, when I'm making a clinical decision about a diagnosis, a treatment, a management plan, I have some awareness that I do not know what the outcome will be for this patient in front of me right now. And that can be caused by several different things. So it might be caused by probability. So I guess in the example you gave there might be certain clinical decisions that we make, such as the prescribing of a certain substance, drug, where we have lots of evidence that tells us how likely that is to work, what the risk of side effects might be, what the numbers needed to treat might be for this population. But I still don't know for this individual patient in front of me, how likely is this to work for this person right now? As a psychiatrist, I become, particularly interested when thinking about the other causes of uncertainty. So that might be ambiguity or complexity. So for ambiguity, that's where there might be missing or imprecise or conflicting information. So it might be in that situation that you're a resident doctor, it's 4 a.m, you're admitting a patient to the acute medical unit and you know they have insulin-dependent diabetes, but there might be missing information. So you might not know what type of insulin that patient usually takes or the dose. There might be imprecise information. The patient might have delirium or acute confusional state and is giving you information about that, but you're not sure how accurate that is. Or conflicting information. The patient might say one thing, the relative might tell you a different thing, their GP record might say something else, but you still need to make a decision at 4 o'clock in the morning about how to proceed with that patient. And then complexity, that might be the same scenario, but then you've added another kind of layer of unknowns. So it might be that patient now has sepsis, which has had an unpredictable impact on their insulin tolerance, yet you've still got to make a decision about what to do at 4 a.m. So I hope I don't need to say much more to convince you that uncertainty is integral to our world as doctors. And, we all can see that, but I think it's in a world where we have increasing technology and increasing data and evidence, it's really important to think about what role does uncertainty have and how should we respond to that as doctors? That's, I think, the key kind of question. And how can we support our more junior colleagues, our colleagues, to develop those more positive responses?
Jason, medicine can be an art and a science, or a merger of art and science together. And I remember training with a very famous pediatrician called David Haig, and his wise words would say to me, if nobody comes back, you're admitting too many people. And he taught me to deal with uncertainty, to be comfortable with risk. It feels very different at the minute. How do we address this, and why is it different?
So within your incredibly important questionnaire, there are so many different things we could unpick and start to think about. So from an uncertainty perspective, we know that the way doctors respond to uncertainty will influence how they think, how they feel, how they behave. So a lot of my research has looked at how our responses to uncertainty might influence our emotional responses. So am I more likely to develop stress, anxiety if I'm less tolerant of uncertainty? But as you say, we also know that those doctors who are less tolerant to uncertainty or have less positive responses are more likely to admit people to hospital, are more likely to order excessive investigations. And that comes from a place where actually you use the word risk. We need to then start disentangling the difference between risk and uncertainty. So it might be that to effectively manage risk, so I think when we're talking about risk, we're saying, well, look, how can I do my best to reduce the likelihood of this negative outcome for this person? So to mitigate risk, I might be in a position where I'm admitting people to hospital or ordering additional investigations. Now, I might be effectively mitigating the risk for that particular problem, but in doing so, I'm not necessarily responding to uncertainty positively. And although I might mitigate the risk of a negative outcome for this particular condition, actually I might have negative unintended consequences for the broader patient, because admitting people to hospital might be associated with other problems and difficulties over time. So risk and uncertainty are often used interchangeably, but are not the same thing. The actual question you asked, which is the, I guess, $1 million question, isn't it? How can we therefore support doctors and resident doctors to more effectively sit with uncertainty? And actually, there's quite a lot of evidence now, of which I've contributed to some extent, but there's a lot of research from others to think about how we can better support doctors to sit with uncertainty. So that might be in your role as a supervisor, as a resident doctor yourself, or as an NHS trust. Like I can think and talk through that shortly. I guess the final thing I'll just do before thinking about that is I'm trying to use my words very carefully, as you might see, and I'm trying to not say tolerate uncertainty. A lot of the literature talks about should we tolerate uncertainty more, but I think that's perhaps slightly too simplistic. And actually, we need to not forget the important role that uncertainty can play for doctors, and the situation where it might be a positive thing. So actually, if we have an immediate negative response to uncertainty, that could be a positive thing in some circumstances. It might actually activate something within us as a resident doctor that says, oh, something's unusual here. I might need the support of my seniors, or I might just need to pay more attention to the information I'm receiving here. So I don't think it's just about producing a population of doctors who are more tolerant of uncertainty. I think it's trying to help people sit with uncertainty, perhaps for longer, and to recognize the transient negative emotional experiences when they get them and know what to do with it, really.
It's almost sort of naming it, really, isn't it? And you see some cases where your gut is just telling you this doesn't feel quite right. So it's having that cognitive awareness, or I suppose if you're ignorant of the outcome, and sometimes more cases than others.
Absolutely. I think it's really important to try and support, well, I guess I talk about resident doctors, but ourselves, just to recognise those situations where, we feel that.
And I think if you think about the all doctors and all practitioners are tolerant, as you said, tolerance is the wrong word, but this awareness and dealing with uncertainty changes as you transition to more responsibility. And a lot of our training pathways are to get people to that senior position, whether that be SAS or consultant. Because there's huge variation in consultant practice and admission rates and discharge rates.
Absolutely. And medicine is a broad church. I mean, maybe we don't want a whole population of all doctors and all specialities and all seniorities becoming more tolerant or having much more than, I guess, relaxed attitudes towards uncertainty. Actually, maybe in certain circumstances, we want people to be less tolerant or to have not the same response to uncertainty. I think we need to, also have an awareness of the potential benefits and having a range of experiences within our population of doctors.
Can I just come in here then? And do you think that this is our intolerance of uncertainty starts at medical school? Because I went to medical school quite a long time ago. I'd never even heard uncertainty or tolerance of uncertainty. It wasn't talked about. We weren't taught about clinical reasoning. We talked about how we make decisions. We didn't even know the phrase metacognition. And then you all of a sudden start as a foundation doctor, resident doctor, and people start to talk about these terms of uncertainty, ambiguity, risk-taking. And it's like, what is this? I've never even heard of this.
It's a really important question. And I think, where should we be supporting our learners, undergraduate, postgraduate trainees, to begin to understand this? And there are two different schools of thought. So some scholars would say, actually, in medical school is too soon, and people can't really engage with this idea and this concept until they are practicing as a professional, practicing kind of autonomously in those early career roles. Others would say, oh no, as early as possible, we need to be introducing this at medical school, and we need to be at least introducing the concept. And I think I'm the same as you. I'm not sure I ever really had an awareness of uncertainty at medical school. As a psychiatrist, I've become more interested in medically unexplained symptoms. I didn't know that was a thing at medical school. I didn't know that existed. And I think we are getting better at introducing this construct earlier. So some of our work has looked at problem-based learning, for example, and how you can, as a problem-based learning tutor, role model more positively kind of responses to uncertainty. So I think it's really important that we try to introduce this early, but equally be realistic, be kind on those learners who are very early in their career, and struggle certainly more to see uncertainty as something that is integral to medicine, and see it more as a kind of internal flaw, that they are uncertain, and they make an assumption that might be more about their lack of knowledge rather than the reality of a lack of broader understanding of knowledge across medicine. So I think it does need to start early, but again, there's quite a lot of growing evidence as to how you can do that, but you do need to introduce it carefully at medical school, and you need to be mindful of the potential negative consequences of introducing this for a population of learners or medical students and not truly supporting them through that uncomfortable feeling.
So for many of our people who may be listening, who will be supporting students, resident doctors, you talked about some evidence base about things you can do. Just from a really practical point of view, how do we discuss this on the ward in our patients so we start to get what's been your experience and what sort of has worked?
So that's a really important question, and I think I'll talk that through from the then perspective of a ward consultant, senior doctor, specialty doctor. What can we do? So the first thing I think we need to do is have an awareness of our own responses to uncertainty, also an awareness of the responses of our resident doctors. Before answering your question fully, I think there's one really important concept that we need to have another awareness of, and that's the impact of transitions. So there's quite a lot of evidence now that as doctors, as learners move to a new role, the process of moving to that new role will have a significant negative impact on their ability to sit with uncertainty. So that might be moving from preclinical to clinical training at medical school. It's definitely moving from final year medical school to foundation training. It's probably moving from foundation training to specialty training. And it's also going from specialty training to becoming a consultant. We know that those things impact on a person's ability to sit with uncertainty. And as a supervisor or as a doctor on the ward, that's particularly important in those first couple of weeks of a placement. So you need to have less or different expectations of your colleagues and resident doctors in the first 2 weeks of their placement compared to later in the placement, because we know transitions are really important. And when you start to have an awareness of that and have reflected on your own responses, the really practical things that people can start doing on the wards will be things like talking aloud in MDTs or in ward rounds, naming it as a senior doctor, trying to demonstrate intellectual candor in those circumstances. So just being open about, this is how I see this situation, this clinical problem. These are the things I know. These are the things I don't know. This is the plausible best or worst case scenario. But trying to share some of that, honesty and vulnerabilities, intellectual candor, balancing the vulnerability with the credibility. So it's not that I don't know what's happening here because I'm an incompetent doctor. It is integral to medicine, and it is not possible to know what the outcome will be here. But this is how I see it. And this is how I, as a senior, would start to work through that. And that might be in a very practical way in MDTs and ward rounds. It might be through supervision. So in psychiatry, we're incredibly fortunate that we have kind of another level of supervision, which is psychiatric supervision, an hour a week, hopefully delivered in a consistent, safe place, in a psychologically safe environment. Really important to support our resident doctors in that way. But then also, transitions, incredibly important as well. Having that awareness, I think, as a senior doctor on a ward, really important.
I must say, I think the biggest transition for a lot of people now is getting their consultant. I think we're very, very good at supporting people. And it might be like stuff which sound quite trivial. You go to an outpatient setting and you've got to make a decision, this child with headaches, do I scan them or not? The implication of potentially putting somebody for an MRI, a GA, for dealing with that uncertainty and that confidence. And I relied a lot on my colleagues, my peers, to sort of, because I felt safe in quite a small team, but I do worry about some of the bigger teams that admit vulnerability of, the stupid question that you think you should know. Any advice for anybody, if that resonates with anybody, have you got any personal advice for people?
Yeah, that's a really great question. And if those of you who can see the visual, I'm nodding a lot as you're asking those questions. It's you're absolutely right. I think the step up from a resident doctor to a consultant is incredibly important and is one that has perhaps not been fully appreciated. I think there's a great paper. I think Anna Collini, looked at this in emergency department consultants, and it's a really important construct, and it's important to name it today. I did, from a personal perspective, exactly the same as you. I was, in a fortunate position where I moved up from an ST6 to a consultant job in the same team, which had some benefits, lots of disadvantages as well, perhaps. But I had a really good peer network of consultants who I felt able, and they felt psychologically safe for me to be able to say to them, I don't know how to proceed here. How would you do this? What strategy would you use? I made a good use of our peer group in doing that. So that was something that was a really useful thing for me. I appreciate other people might not be in such a fortunate position. But actually your question as well also reminded me of an important thing to be aware of as moving to a consultant role, or actually transitioning into any role, is that the evidence also shows us that actually if we want to be in a position to best manage the clinical uncertainty, we need to first try to reduce all of the other unnecessary uncertainty that sits around that. So we're talking here about clinical uncertainty, but obviously uncertainty exists beyond that. Where I'm moving into a new role, where can I park my car? How do I get my lunch? What's my rota going to be? What are my expectations? What is my role? And all of the evidence, particularly the work of Georgia Stevens and Michelle Lazarus in Australia, is kind of saying, well, the more you can do to reduce that unnecessary uncertainty will support doctors, resident doctors, new consultants to better engage with and sit with the clinical uncertainty. And that's in my role as DME. That's one of the things that I think is really important. So as much as we can do to prepare our new doctors to reduce that unnecessary uncertainty puts them in a position to best manage their clinical uncertainty.
And I think that amplifies, just as you're talking, our international colleagues who are new to NHS. There are multiple layers of uncertainty about schools, bank accounts, all those elements that a lot of people are doing some good work on.
Absolutely, incredibly important. And international colleagues, international medical graduates, really important. The 10-point plan as well, that I'm sure we talked about in this podcast previously. Those are really important things for us to get right. In part, because it's just the right thing for us to get that right, but also because actually we know that the educational outcomes will be better as well. If we can get that right and we can best support our colleagues, they will be able to truly engage with training quicker, which is really important, particularly given the complexities of training and the other challenges that the resident doctors are experiencing. Yes, you're right. Really, really important.
I'm conscious I've dominated. Because I'm so passionate about this topic. I'm going to give Amie a chance. She's got a long list of things that she wants to talk about.
I guess I have got a lot to talk about. I'm aware of the time. How we've talked a lot about uncertainty. Can we use simulation to help doctors with uncertainty?
So the short answer is yes. I think there are several different ways we can do that. actually looking, first of all, I'll talk about medical school because there is evidence there around the best use of simulation. So we know that simulation can be used to support people develop better responses to uncertainty. The challenge with simulation, particularly at medical school, is that simulated scenarios are often textbook scenarios in which the diagnosis is relatively clear and the expectation on the person engaging in simulation is that they should find that diagnosis pretty quickly and recognize it, and then they pass the simulation. And I think the challenge is if people are in a simulated scenario where there isn't, or they don't reach a diagnosis or don't come up with the management plan, they assume that they failed the simulated scenario. So actually some really interesting work at medical school to look at, well, what happens if we deliberately write simulated scenarios that are ambiguous and are uncertain? And unsurprisingly, medical students don't like that very much, and it can cause an immediate, quite strong negative emotional response. But if they are supported well in that situation, if they're supervised and they're given a good post-simulated debrief in a psychologically safe environment, that immediate negative emotional response actually in time can translate into more positive cognitive and behavioral responses to uncertainty. So I think, unfortunately, at the moment, simulated scenarios often do the opposite of supporting people to develop more positive responses to uncertainty. They definitely can, but they need to be carefully constructed, and the post-simulation debrief is incredibly important. The other way that simulated scenarios can help, I guess this is from my own perspective as a DME, is that when talking about the unnecessary uncertainty, actually for us, one of the unnecessary uncertainties that people were experiencing as a new doctor working on a psychiatric rotation was, how do I conduct a seclusion review effectively? What are the expectations of me in regards to my relationship with the nursing staff? What is it I'm trying to do? So actually, in hearing that, we developed, as part of the induction before people are on call, a simulated scenario to try and help reduce that unnecessary uncertainty associated with that scenario. So when they're on call and doing clinical work in that scenario, actually, they're really engaging with the clinical uncertainty rather than what is my role here? How should I manage the relationship with the nursing staff? What are the expectations on me, for example? So yes, simulation can be a good tool, but there's also a risk if not used carefully.
And Lee, moving on from that, so we've talked a lot about ambiguity, uncertainty at medical school and postgraduate education. However, when we come to do summative assessments at medical school and postgraduate, we often use single best answer. Medicine isn't like that. So we're trying to teach people, doctors, about uncertainty and to sit with it. But then we're saying, actually, you can't be uncertain in an exam.
Yes.
So it's something that's baffled me for a long, long time, because I don't understand how we can expect our trainees to understand uncertainty in the workplace, but when it comes to an exam, there isn't any.
It's difficult to do more than just agree with you there. I agree. I think it's a real challenge. I think it is a real challenge that MCQs are, fundamentally the things that are assessing whether medical students can progress or not. I mean, even OSCEs, although OSCEs slightly better, there are still, as I talked about simulated scenarios, there will be very clear diagnoses that the learner is expected to reach and things that they're expected to achieve. It is a huge challenge, and I see that when speaking to medical students often, particularly at the time of year, will have a huge impact on how able they are to engage with other opportunities to learn. How close is the next MCQ? I think within some postgraduate specialities, it's obviously still a challenge. How can we get that right? It's difficult to have a single response to that because it's so ingrained within the practice and the assessments of medicine. I think within psychiatry, we're quite fortunate that we don't have an exit exam. So all of our MCQs are done by core training. So actually, as a specialty doctor, you're more able to engage with those other aspects of training that are not reliant or dependent on multiple choice questions, which I think is a positive. And moving towards that, I think, is really positive for our speciality. But yeah, you're right. It's a big challenge.
Yeah. And it's one that I vehemently disagree with, because I'll look at a question, I'm like, well, it could be any of those 5 answers, dependent on the situation that you're in. So it is a challenge. Should we reframe uncertainty as curiosity?
I like it. That's a positive rebranding. Yeah, that
Let's
could be.
let's rebrand it as curiosity, because we want I'm curious, continuously curious, and instead of saying, oh, I'm really not sure what's going on, I'm very uncertain. Oh, I'm really curious as to why I've come to hospital today. Oh yeah, I'm going to do some tests and we'll try and figure out what's going on. And maybe it's just lexicon rhetoric. I'm not sure, but I don't know. Try and reframe in a positive stance.
I think you're right. I think positive reframing could be a really useful thing. Certainly when I hear my colleagues, I'm thinking now about safeguarding concerns within mental health services and psychiatry. We talk a lot about professional curiosity.
Yes.
Rather than uncertainty. So I think, curiosity, I would see that as, back at the start, I talked about the kind of emotional, cognitive, behavioural responses to uncertainty. Curiosity, I would see as a positive cognitive response to uncertainty. I think the more we can foster and support people to be curious, I think that'd be a really positive thing. I think you're right, though. There are kind of negative connotations with the word uncertainty, not just within medicine, but within society. So it is, I think it's a great idea.
Can I just extend on that? Because one of the questions I always used, I think clinical reason, you can get the concept of search satisfaction and then confirmation bias. So you get a bit like the scenarios you talk about, you end up doing the same patterns, you don't think outside the box. And I remember a very clear case of a paroxysmal on origin, a very small baby, and we were struggling for a long time to work it out. And my question was, what else could this be? That we were saying it was osteomyelitis because of some bone lytic lesions. And this, it was that constant, this does not feel right. And so I always say to people, if you've come to a diagnosis, but what else could this be? How certain in dealing with that? And this child ended up having systemic BCGiosis and severe combined immunodeficiency and a reaction. But we got so fixated, and that links to the curiosity and for all of our clinical decisions. I think it's this. But if there is uncertainty, what are my options? I suppose, how do I mitigate that? And when do I know to go there, but not be paralyzed by that? Because I think sometimes if you have that constant uncertainty, maybe I'm expressing my things, I think sometimes we get paralysis of decisions and actions, and we spend a lot of money on investigations.
You completely agree. Yeah, I think paralysis of decision making is a real risk in this. I guess it's something I sometimes see in supporting resident doctors, that when we're thinking about ambiguity, missing, imprecise, conflicting information, often, particularly in older age psychiatry, for example, when trying to make a diagnosis or progress a clinical scenario, the right thing to do is to take a collateral history to try and improve the quantity or the quality of the information that we have. And you can see people getting stuck sometimes where they're unable to move on and make a decision because they're constantly or continually trying to reduce the ambiguity, and they might have 2 or 3 collateral histories and they want a 4th or a 5th. When I guess your experience might be actually a 4th or a 5th collateral here. No matter what it says, it's probably not going to improve our quality of information and put us in a different position. We just need to make a decision and move on. So I guess supporting people to know when they have enough information to make a defensible and good enough decision to move on is really important. But as you're saying, that the strategies you've talked about there are exactly the kinds of things we'd hope people would do with their resident doctors, so they can see, consultants really kind of, thinking about this, struggling with this, not struggling, I guess that's a negative word, isn't it? But, sitting with this and working out how to progress important decisions.
I think struggling's okay. I don't even to a negative thing, say, actually, this doesn't fit. It doesn't feel right. I'm struggling. Talk to me. Have some ideas. I was very known for my decisiveness. I was on the other end of the spectrum. I'm also well known for my timekeeping. So we're coming close to the end. And I think as I said earlier at the start, I think we could talk for hours on this topic. Before I summarize, Amie, I don't know if you've got any final points or opinions.
I guess there's one. I guess it's more of a question or a thought process or something to think about. Is we've talked a lot about uncertainty with our students. It's the communication of that uncertainty / curiosity to the patient.
Yeah,
and I think that's where we can educate our trainees a lot by role modelling good communication of curiosity / uncertainty to our patients, and how can we do that in a good way that ensures the patient feels safe and the doctor feels safe.
Yeah. And before I summarize and bring us to a close, Jason, I ask all of our guests this question, which is, if you could go on a time machine with all of your knowledge and experience and give yourself some advice when that first year of being on the wards as a new doctor, what advice would you give yourself?
I should have prepared for this question. I've listened to your podcast before, and I remember thinking how difficult a question that would be to answer. I think probably this is not a particularly original answer, but I would try to encourage myself to enjoy the process as much as possible rather than seeking the destination. I think, I recall thinking, let's get through training and get to be a consultant. And then I had a real wobble when I got to being a consultant, not because necessarily of the step up, but just the idea of what next, what do I do now?
Yeah.
And it took me quite a while to work out what I do next. But I think to try to enjoy the process, as much as possible, and enjoy the opportunity to do all of the specialties that you're never going to end up doing, which I think I did, but just do that. Enjoy the process, enjoy the journey.
Thank you. So I'm going to summarize just some of the learning I've taken away, really. That uncertainty is different from risk. We need to be consciously aware of how this affects us in terms of our emotions, our stress, our behaviors at work. We should role model discussing uncertainty and vulnerability, which I think is good for the team and potentially the patient, as Amie said. This is amplified during transitions and improves as clinicians. And if we could reframe it from being curious. So thank you very much.
Thank you for having me. It's been a pleasure speaking with you both.
Thank you so much. And thank you to all of our listeners out there. Thanks for listening. Goodbye.
Bye.